Have you all seen the lung model before? So one of the things that I just want to show is so I've just met this lung today, so I don't know the compliance, I don't know the resistance, I don't know what size animal it's come from. So we have to ignore the settings, okay, because they won't be real. But it's all about the principle of what we're doing. So I'm looking at these lungs, and I found something where I think I'm ventilating reasonably. I've got a pip, I've got a peak, my graphics have changed. And I've got a pressure volume curve that looks sort of reasonable. It looks like a reasonably compliant lung. It looks, and obviously we can't normally see this, which is what the beauty of looking at this lung is. So, for all intents and purposes, for argument's sake, I've got a pip of 24 over 10. It's giving me a tidal volume of 182 mils. I've got a small leak, which isn't bad at all. It's giving me a mean airway pressure of about 15. So I'm looking at that lung with a mean airway pressure of 15 centimeters. And one of the things that I think is when I was training, we used to set peeps at 3, and then 4, and then 5, and now we're becoming happier with much, much higher. If we look at why that might be, and I think in conventional, before we switch to oscillation, which I'll show you in a minute, if we look at why that might be, if you look at what happens with that lung, you've completely changed the dynamics of the lung. You've changed the dynamics of the lung in that now there's nothing to hold it open. So when breathing out, that lung will now completely collapse. And you'll see far more pink areas appearing on the lung because you've lost your peak. Now, even though I've dialed in 0, it's managing to exert a little bit of peak itself. So the most important thing is when, and what we'll do is we'll look at this pressure volume curve in a second. The most important thing is to realise the difference between your pip and your peak. I've dialed in 28, but actually this machine can't give it at the moment, simply because it's starting from such a low peak that it's unable to generate that pressure because there's so much lung to fill. So the difference between 28 and 0 that I've dialed in there is 28 centimetres. What pressure do we call that? Yeah, it's also that the difference between the two is the driving pressure. So yeah, so that's how we're driving our lung, 28 over 0. The 28 over 0 is not very good and not very efficient. So if we look at the lung, and we also look at this, if I increase that, let's say I put it to 4, I begin to see a slight difference. Now look at the change. Did you see that change? So let's do that. Let's do that again. Where this loop is taking it. And what happens is I've now got a driving pressure of 28 minus 5, which is 23. And if I put my peep up even further, if I put it up to 8, I've now changed my driving pressure to 20. So the excursion that I'm using to open and close the lung is now 20 centimetres as opposed to 28 centimetres. And we know by having a higher peak and not allowing this lung to collapse means that I'm holding the alveoli open, and that is what's helping with my oxygenation. Ignore the fact that it's 8 or 10, it doesn't matter. It's the fact that we're needing to generate a peak to improve our compliance and to ease inflation and give us a better looking curve. This curve is nowhere near as fat as it was. The length of time it needed to inflate the lung was quite long, and now it's shortened. Over time it's now shortened because I'm giving the baby peak. And so to open the lung is just taking here till about 20 before the lung opens. Now, are those lungs well inflated? Can we tell? The only way that we can tell when we're looking at the baby is if we know the baby's weight and we can guess a tidal volume. Now, so I've got a tidal volume here. and I've got a Tidal Volume 183 mils, but I don't know the size of the piglet, so I can't tell you whether it's accurate. But it can give you an idea. If you want 5 mils per kilo, and you put in your targeted tidal volume of 5 mils per kilo, then that will give you a rough idea of how many mils you need to inflate the lungs. Now, as I said, we've got very little leak here. We also get some other measurements here. Resistance and compliance. These numbers are just useful guides to look at as you change your ventilatory parameters. You can get an idea of the compliance of the lungs as to whether you make any improvements. Now the resistance is mostly tubing, ET tubes, trachea, etc., narrowness. But your compliance is your intrinsic elasticity of the lungs. And sometimes, if you keep an eye on that number, you can actually sometimes get an idea of how you can do better. So I think some of these numbers are here to help you, some of these graphs are here to help you, and that can be very good. Now, what if I overinflate this lung? What if I put this pressure up to 32? I'll get a warning, perhaps. What's going to happen? What differences are going to happen now by changing that pressure? I'm not sure this ventilator is going to be able to reach 32 with the compressor it's on.
It's going to take longer to inflate. The curve will go
faster.
faster.
So I'm going to try and get to inflate. I'm going to try and inflate it for longer. My driving pressure has now increased again. So when I lowered the peak, I'm now going from 32 minus 8, so that's 24. So my driving pressure has gone from 20 to 24 centimeters. And I'm not sure on this one if I can keep going up, whether it's going to let me go up. What am I trying to get here? Do you know what happens here at the end of inspiration? The beaking, yeah. So what I'm trying to get is this to tell me I've overinflated. Now when I look at those lungs, they still actually don't look overinflated because these red areas are signs of underinflation. So one of the things, so we'll just drop the pressures down. One of the things that I'm sure you have seen a number of times is basically what happens when we get a disconnect or when there's an accidental extubation. And what's interesting is the difference between whether you've got the right settings or not, is how a lung recovers. So who has inline suctioning? So inline suctioning means that my suction is here, and I just feed my tube down and back up again, and that's it. Nothing has changed.
Without opening the switch.
Correct. So inline suctioning is unfortunately not cheap, but it prevents you breaking a circuit. So these lungs, fortunately, are very, very compliant. Unfortunately for me, because I like to demonstrate really difficult lungs, these lungs are very nice. But if I'm now going to suction this baby, this is what's going to happen inside to the baby. So that's what's going on, and you're sucking the baby, and the baby starts to desaturate, and the nurse goes, well, it was just a quick procedure. Now, these lungs are very compliant, but look at the length of time it takes to get back. Now, during that time, you might well have turned up your FiO2. If these are very stiff lungs, that can take half an hour. So what are you doing for half an hour while your lungs are underinflated and you're desaturating, and you've turned your FiO2 from 40 to 80% and your baby's still not good? That's what we're dealing with stiff lungs. But it's also, if I have the wrong ventilator settings and I just didn't have my lungs very well inflated, but at the same time I still wanted to do suction because there were a lot of secretions, and I'd yet optimized my baby, and I'm starting my suction and I'm reconnecting. If you were never on the right settings and you were still working your baby up, it takes even longer. This is a nice compliant lung. to get ready or to get better. So when I look at that, I think, yep, we're struggling. I know I've turned the PEEP off and we've got a PEEP of 3, but that's still a PEEP of 3, and that's the settings I used to use 25 years ago. We thought a PEEP of 4 was dangerous. So these lungs are still not normal, and these are very good lungs. These are lovely and compliant, and I'll prove that to you in a minute. So now look at the effort, because I've got a very low PEEP, to try and get to open. I want that to be nice and thin. Well, of course, if I had the baby set up correctly in the first place, I would be doing better, and this will gradually adapt. But even by putting the baby back where it was, it's taking time to inflate. So, what can you do? What would you do if these were really sick lungs? You've, for whatever reason, disconnected or re-intubated, and your lungs are down, and your baby's desaturated, and they're very stiff lungs, and you put your baby on your pressure. My baby's back on the normal pressures. I'm on 24 on 8, and it's not working.
What setting? Temporarily.
Yeah, okay. So Craig was talking about that, wasn't he? Stepwise recruitment. Who uses stepwise recruitment? Do you use it?
Yeah.
So what do you do?
Increase the people.
What do you increase?
Increase the people, increase the PEEP and the PIP.
Right, so you increase them both together, because if you don't, you'll alter the driving pressure. And you can exactly. So if I wanted to recruit, I might put that up to 10, and I'd put that up to 25, and I'd wait and watch. How long do you wait and watch for before you do it again?
Between 2 changes?
I've just put the PIP up by 2 and the PEEP up by 2.
To the previous measures.
My baby is in 100% oxygen.
Saturation?
And the saturations are 70-80%, and therefore I put my PEEP up by 2 and my PIP up by 2 because I think I need to recruit my lungs. How long do I wait before I do it again? Nothing's changed.
Few minutes and they will change the...
Yeah, I mean, I don't know the right answer. I probably wait a couple of minutes before I would do. I don't know whether this machine will allow me to take it up much higher, but actually, can you see it getting thinner? This is a very nice compliant lung.
And in the meantime, you're waiting for the saturation to...
Correct. So my saturation is sitting here at 75-80%. Okay, and I'm in 100% oxygen. My lungs are collapsed. The only thing I can do is recruit them. Now, how do you know they're collapsed, and how do you know they're those grotty-looking lungs that I showed you just now? Well, that's because you usually have an idea about the pathology of your baby. You may see a whiteout on the chest X-ray. You may know there have been prolonged rupture of membranes. You may know there's dreadful RDS. You usually have an idea that lungs, or you've looked at the resistance and it's gosh, it's hundreds. This is only 51. Sometimes this is in the hundreds, and you can see very poor compliance. So we know this isn't a poorly compliant lung, but a stepwise increase is a very nice way to inflate. And in actual fact, we could probably go further because there's still some underinflated lung tissue here. Not much, but there is. So whether the machine will deliver it, I think the machine's struggling. It's not the machine's fault, it's the pressure of what's coming out of the compressor, because we're not in a hospital setting. But I could try and put that up again by a couple and just see where we go. I'm not sure it's going to make a big difference, because I'm not sure. Maybe I'll get a bit higher. It's reading 26 on 15, possibly, and maybe that'll get a bit pinker. Now, how long would you do that for, and how high would you go?
So the baby saturation is stable.
Settings are changed.
Yeah. So what do you see happening if this was a live model? What would I be showing you? What would be happening as we did this?
The word of breathing is according if a baby is simultaneously breathing or is totally sedated.
You are seeking for
Yes, I want to know how well I'm doing by doing
And
this.
the graph will be getting.
So I've got some monitoring to look at my implanted graph, but basically we only have a very simple measurement, and it's the saturation. All of a sudden it goes, and it often very quickly goes 75, 80, and you go, yes, I've opened the baby, and it's like the lungs sort of go, and we know with Laplace's law, once they're open, they're easier to stay open than when they're very, very small and collapsed. So quite often you see that saturation suddenly hit 100%. And the trick then, of course, is to go down on your FiO2, but now you can start your stepwise de-recruit. So you've reached there, you turn your oxygen down and you realise you're there. You get back to 30, 40, 50, 60% very quickly. Then you can start coming down. The question is, where do you stop? Okay, so that's one
Reaching
method.
desaturation, I think, is a bad sign.
Well, yeah, exactly. Well, it's one method, but it's a bad sign too. Yeah. So, how do you know when to stop?
When I reach minimal settings to keep the lung open.
The least setting, the saturation is stable on it. The least setting, the baby did not develop the saturation, so it's the best pressure for the lung to be open.
At least the previous
Yes, but
one.
how do you know where that is until you start desaturating? How do you know to stop?
The previous ones.
Yes, so
previous
you
measures
can
I
look
want.
at where you were previously. Say, my baby was not good on 24,
But
on
what if it's a
10. I
baby
want to
that-
go. I want to be higher
What
than
if it's
that.
the newborn with RTS that you're just recruiting?
Yeah, you don't know,
You
do
don't
you?
have anything.
You don't know. So some people will go by and bang, the baby will crash, and they'll keep going down. And then, oops, you lose the baby again, and then you re-recruit and you don't go down that far. You stop one above or two above. That's one way to do it. The other thing is with tidal volume, is to go down till you've got about 5 mils per kilo. But don't forget, some babies need 6 mils per kilo, 5.5 mils per kilo. This is all a guess. So you can do it if you've got a flow sensor with tidal volume, or you can do it to where you left off, or you can do it if the baby crashes and you know that's the crash point. And then we try and inflate the lungs again. So I think in conventional ventilation, we normally regard this as a pretty good way to ventilate. Let me take the baby down to, let's go 22. Let's have 22 on 8 for a minute. See what the lungs look like, because I want to
If you
do
please,
something.
does the work of breathing affect my judgment? If the baby is having a difficult breathing or the signs of respiratory distress, that means my ventilator is not acting so well.
Yeah, I mean, usually a baby is intubated because you were worried about the work of breathing, so the ventilator needs to make sure that it's helping the baby. So if you think a baby is stressed when it's being when it's intubated and ventilated, then there's usually some mismatch. Something is wrong. Why is the baby stressed and why is the baby working? So we then need to look at modes of ventilation and synchrony and eye time and our graphs. And although I'm not, where's my just default. There's my defaults. Sometimes these can be very, very, very helpful at working out whether you've got the right eye time, the E time. I'm not going to go into, you're going to talk graphics over there. But if you understand your graphics, that can give you a bit of a clue as to why your baby's asynchronous and keeping your.
No, I'm talking about we are judging when to go down, step down. So I'm asking if the work of breathing and the clinical point of view, the working breathing can be helpful as a judging tool.
It's not great in an intubated baby unless the baby's asynchronous, and then you need to synchronize. One of the I didn't talk this week on conventional ventilation. I have a morbid hate of SIMV. I mean, I think it's a dreadful mode of ventilation. Why give a baby 20 nice breaths and then make it struggle and suck through an ET tube for the next 5, 10 or 15 and then think you're helping it by giving it some pressure support? Why don't you just have the baby on pressure support anyway, or PTV? So I don't like SIMV. For me, that's fine on very big babies who are perhaps hyperventilating and you want to give them a rate of 5 or 10. But in our small babies, I find it very cruel, so I don't like it. So I find babies are much happier when they're triggered and synchronized. So we tend to use, my commonest, the way we ventilate in Corniche is PSV plus VG. So we pressure support and volume guarantee. Except on day one, when pressure support doesn't always work if you've got stiff lungs, so we use PTV and VG. But I say I'm not going to talk about that now. So yes, I take your point, but ordinarily, no, I think you need to overcome that with other parameters. Okay. So what I wanted to do is now say, look, here's my mean arterial, my mean airway pressure here. Let's drop that to 20. I think this lung ventilates quite nicely on 20 on 8. I think that's, can you just see it beginning to get creases?
Yes.
Okay, perhaps we're just a little bit underinflated. So let's just assume that we wanted to oscillate this baby. Okay. How do you calculate it? How would you set it up? Let's just assume now this is a baby I've decided that I want to oscillate because, for whatever reason, let's not forget my reasons. I want to oscillate this baby. How are you going to switch from this to that?
Disconnect the baby.
So I've got a map of 12.
Increase the left 2 above the convention.
2 above, okay, so I'll use a map of 14. What about my frequency? How do you choose your frequencies? We are... But ordinarily, once a frequency is set, it isn't something, although it has an effect on CO2, it isn't something we're routinely changing. We normally set a frequency and in general leave a frequency. And there are theories, which I can't quite show you yet, about how that works and why we do that. But suffice it to say, I don't know what this big is. So let's choose 10 hertz and see what happens. How do I choose my delta P? Sorry?
1 to 2 minus the rate. If the rate here 30, it will be 28.
Okay, so you're looking at a rate here to choose your delta P. Okay. Does everybody choose their delta P that way? No? How do you choose your delta P?
Usually you go by the mean is 14, you set it like 10 above and 10 below.
So if your mean airway pressure here is well, the map we're going to set is 14. So your delta P would be
30.
So double. Double. Okay. So double the map. Any other ways?
Look at the wiggling.
Look at the wiggling, yeah. Look at the wiggling, and some babies wiggle and some don't because they've got edema or the like. Yeah.
Okay.
Okay.
Chcesz tylko поставити сагамаш на прожектор?
Thanks. So we can have ordinarily you can have up to. I agree with all of those in a way, is because nobody really knows the right answer. Because you need to observe and you need to take your CO2 to find out if you're doing the right thing. But ordinarily 2 or 3 times the map is a very reasonable way to set your delta P. I hadn't heard of the one of taking the BPM and adding to it. I didn't know that one, but I'm sure various people have different ways of doing it. What I wanted to show you was that for me this is time, this is pressure. And the mean airway pressure, if we didn't have any wobble, the mean airway pressure is peak. We're basically setting a peak. So we've set a map of 14 here. That's a peak of 14. All we're using is a flex. All we're using is a peak of 14. So here's my peak of 14. And then we're going to wobble it at a certain height, which is my amplitude. And how fast we do it is at the frequency. And so And so all we're doing really is we set the frequency as to how fast this is going to occur, and then how vigorously do we wobble. So for me, the whole concept of high frequency is very, very easy, because you're just wobbling around a peak. You're just wobbling around your mean airway pressure. And I think it's very, very easy, an easy concept. But the reason we use higher frequencies in smaller babies is simply because the amount of CO2 that's removed and the amount of shake is much, much less. It's much more gentle to have a high frequency than a lower frequency. So if you have a 15 hertz baby as opposed to a 5 hertz baby, they're very, very different. And there's something very awkward about seeing a 26-weeker banging away at 7 or 8 hertz. I just don't like it. So a gentler way to ventilate is to have it at a high frequency. The term baby, of course, is very robust. So the strange thing is you increase your, if you increase your amplitude, you will lower your CO2. But if you increase your frequency, you need to lower your frequency to remove your CO2. So a higher frequency is less efficient at removing CO2. That's why sometimes in the volume aspiration we have to go much, much lower. Just seeing if I have another picture that helps demonstrate that. And you know about going up on the pressure volume curve with conventional ventilation. Actually, it's exactly what we're going to do, the same thing with oscillation as to how we ventilate our babies, which I'm going to demonstrate to you now. So we've decided we're going to have a frequency, a mean airway pressure of 40, and let's go for a delta P of 30, shall we? Something like that. And we've decided a frequency of 10. So if I were to change my mode and I were to change to high frequency, and I've got a 10 there, I've got a mean that I need to put up, what did I say it was? 14, there we go. And I've got a delta P that I need to put up, we'll try 30. Won't go more than 30 at the moment. And confirm that, now watch. So we had slightly de-recruited, we've switched to oscillation, we've gone 2 above what we were. Is that what we're getting? Nearly. Mean pressure 15, yes, maybe a bit more. We're at 10 hertz, mean airway pressure is 15, 100% oxygen. Now sometimes, in a very non-compliant lung, that simple switch, that simple timing, imagine if you have to stop this and put on a sensor medics, your whole lungs collapsed again, which is why we like ventilators that are all in one. But this is still not a fully recruited lung. So, and you may suddenly have gone, switched to oscillation. I will often get a phone call, or I'll be there on the unit and someone say, Dr. Eason, it hasn't worked, the baby's now in 100% oxygen. I want to go back to conventional. And I say, you haven't tried the baby yet, and was everything optimized? So we do know that if you're hypovolemic, this could be a problem. Okay, but ordinarily, I've started to ventilate. My little leak there. We've started to ventilate, and ordinarily, it may be simply that the reason we've switched to oscillation is because these lungs are very non-compliant, and going 2 above just wasn't enough. So this is where in oscillation we do exactly the same as in conventional, which is the stepwise recruitment. Do you all do that with oscillation? Yeah?
Yeah.
And it's exactly the same. It's no different. But you don't touch the frequency. You don't touch is the delta P really only 12? Thank you. Why that doesn't work. I'm getting a bit of a wobble now. Now we can see those who like wobbles, this is a wobbler. And then I can go up on my mean airway pressure. And this is probably easier than conventional ventilation because you just have to change your high frequency. Sorry, just have to change your mean airway pressure. So one button, two at a time. And I hope you will see that as we go up, we will begin to recruit this lung vessel better. We thought it wasn't badly recruited, it de-recruited a little. But as we go up on the pressure, and I'm going fairly quickly for demonstration purposes, we will begin to start to inflate these lungs better and better. And you'll know exactly the same way with your saturation monitor. Once your saturation monitor is starting to, it's peaked, it's going up to 100%, you can start moving your oxygen down and then feel that you've reached your mean airway pressure, and you knew that you wanted to get to 14. You may well be able to get to 14, because don't forget 14 is still 2 above what you were on previously. So once you go onto oscillation, you can recruit. Now how high will you recruit? How far will you go? So how do you know when you're over the standard? CO2, well, you can't. So one of the unfortunate things about oscillation is you can't measure end-tidal CO2. I love end-tidal CO2. I use it on all my babies, but I can't do it on oscillation. Oscillation, ideally, the recommendation is that you have transcutaneous. Do you use transcutaneous? No, neither do I. But it is wonderful for making sure that you don't overcook and overdo a baby. Because oscillation, we may think we've got the frequency right, we may think we've got the delta P right. You never know till you've got your first gas. So my question to a lot of my doctors is, how quickly do you do your first gas once you've started oscillation? You've got no end-tidal CO2, you've got no transcutaneous. I've now had my baby on for, 3 minutes. When should I be doing the first gas on a baby you put onto an oscillator? I'm asking you. I'm recruiting. But I'm recruiting for oxygen. What I don't know is what my CO2 is. So so let's just for argument's sake, half an hour's up and we do a gas. And my CO2 is 15 millimeters mercury. How good are you feeling? I'm feeling awful. I'm feeling horrible. I've just compromised my baby's brain. Yeah, much earlier. Recommendation is actually, if you have no monitoring at all, to try and get a CO2 level in 5 minutes. And the commonest answer I get is 30 minutes. The commonest problem I see is hypocarbia. It's iatrogenic, it's avoidable. Not in my country, maybe not in your country, I have no idea. USA, unbelievably medico-legal, they will sue the pants off their parents. And that's not a reason why we should do anything differently. We should do something differently because we're good doctors. And I don't know whether the right answer is 1 minute, 5 minutes, 10 minutes, 12 minutes, I don't know. What I think we should know is that we should be worried about it, and we are aware of it, and we're looking for it. All I know is that I don't like the answer 30 minutes. Oh yes, absolutely. An oscillator is unbelievably powerful. Unbelievably powerful. 10 minutes definitely, which is why we'll usually say sometime after 5 minutes take it down. 30 minutes, thousands of times. Too many that make me worry that 30 minutes is just the wrong answer. Which is why I would do it less, but I don't know when less is. I think that's up to you and your clinical situation. So now we've let this baby go a little bit, maybe we can pop it up a little bit. and we can start to recruit. I think you have to do what you feel comfortable with. You have the information, you deal with it, you make your decision.
You stated after 5 minutes. When do you repeat it?
It depends on the result. So the answer is always, well, it depends on the result. So let's say your CO2 is in a nice range, you're happy with things, maybe PO2 isn't good enough, you know that because you're in 100% and 100%. But it's not so crazily different that you don't have to make it. But let's just say your CO2 was 30 or 35 or 40, you might go, oh, I think I might drop my delta P a bit. It's not going to affect anything you're doing except to perhaps help you prevent hypotension. And then maybe if you're a bit more relaxed about it, 10, 15
It is
minutes.
reasonable, and 5 minutes were not enough to recruit all the lung. And I'm still having more lung recruited. Would I repeat it even if it's good? If I have a good blood gases and but
So that's where you
I'm
just
afraid of
so that's
over-recruitment.
so that's where you just have. I can't answer that question for you. I mean, I think that's sort of something how we feel about how we're practicing. But in all the literature, the recommendation is not to do this without transcutaneous CO2, and the reason is for a very good reason. So the rest of us, myself included, have to decide how frequently to do gases. And I think I don't know the answer, except that some people are cautious, some people are less cautious. But I think I would just be, what's happening? 3 hours left?
Yes, 3 days.
No. So I'm. Let's just pop this away. Let's go crazy. Let's just really inflate this lung up to 30 or so. See if I can get rid of any of these red marks. I'm not sure I will. The lingual is normally a little bit underinflated. But anyway, and then let's. Yeah. So I've got a mean airway pressure, and I said I was going to have it about 24. So I've recruited, I've come down to 24. I've said I've got a fairly compliant lung, but once again I've got inline suction, you haven't. So we do our little bit of suction, and we know in oscillation we really don't want to do that. And we connect it. And one of the problems in reconnecting with oscillation, this lung is beautiful. This lung is going back to normal very quickly. Just remember your pathology. That can still take half an hour. So once you've disconnected and reconnected, and the nurse or somebody calls you and said, the baby's desaturating, it's in 100%, what do I do? It's a recruitment maneuver. And that's the commonest thing that we do. But we now have inline suctioning. It's made a huge difference. But unfortunately, it is a bit expensive. So I think don't think. Suctioning. Yeah. So let's see what this baby stage. But let's see if I can see if it'll recruit a bit there. So we're doing a bit of suction. Okay. One of the things that the lungs collapse. And we reconnect. And just see how long that takes. I just have to tell you this is quick because it's a nice fresh lung. If I had this lung a month later, it'll be slower, and a month later after that it'll be slower. So as the lung gets a bit old, it's preserved. So I don't think I'll have taught you anything dramatically new, but I just do think it's always good to recap our thoughts about what the lung is doing underneath when we can't see it. And sometimes the things that we do, or we're called to a baby, and we need to understand the pathology, and we need to understand what some of the actions should be as to why this goes wrong. So it looks like we've run out of time. I'd love to talk to you for a lot longer on this, because there's lots more things to show and tell you, and we could have done all sorts of graphs. But time is time. Isn't that right? Right.
Okay.